just as often as you're looking at the vital signs and looking at the heart, measuring the blood pressure and looking at the heart rate and oxygen saturations, you're actually writing these. And the reason this is important is sometimes trends in medicine are very helpful. As you know, doing critical care, you kind of learn to be an investigator, and you kind of look at trends, even though at that moment things may be good. But if you see that the blood pressure, just 5 minutes ago was 180 over 100, and next minute it's 100 over 60, even though 160 is probably, that's what my blood pressure runs, that is still alarming. That suggests a trend. And by following charting, you can actually open your eyes to trends and things that can occur that are unexpected and prevent a catastrophic complication before it happens.
You next discuss the need for continuous and vigilant observation of the status of the patient during sedation. And in this case, you found this to be an egregious violation, referring to it as abandonment of the patient. Can you describe your findings and your rationale in that regard?
Right. Like we mentioned earlier, it's imperative for the physician to be observing the patient at all times. I mean, this is the very basics of medicine, is really putting your patient first. And in this case, it was clear that there was a period of time when Mr. Jackson was basically left alone and was not being monitored. And that, in somebody that is receiving sedation, is really not acceptable, and that's why I felt that was an extreme violation of the standard of care.
And why is that continuous visual monitoring so essential?
Right. I think it is even more imperative in circumstances where some of those more advanced capabilities and eyes are not on the patient. For example, if you're not in the ICU and you're not have all those advanced devices, I mentioned capnometer, that device that measures the exhaled carbon dioxide, which can sometimes detect the problem before the oxygen levels decline. It's even more so important to actually monitor the patient, to actually be looking at the chest rising, to be seeing if the airway is obstructing. You can sometimes look for, actually you can always be able to look for the chest rising when the patient breathes in. And sometimes when the airway obstructs, there may be a paradoxical movement between the chest and the stomach, and that tells you that the patient is having difficulty breathing. So it's really imperative to be constantly observing these patients. And again, I'm referring to a situation where you do not have an artificial airway, just to be clear, because in the intensive care unit we have patients on a ventilator, and although there's a nurse, they may not be looking at them all the time, but they have a machine breathing for them.
And they're hooked up to all the monitoring equipment.
That's correct.
Now, you also touched on the concurrent administration of both the benzodiazepines in this case and the propofol that Dr. Murray admits to in his statement. And you commented on this concurrent administration you found to be an extreme violation in the standard of care, correct?
That's correct.
And can you please explain that?
Yeah, there's, as we talked about earlier, the continuum of sedation, and that there's a very fine line between going from moderate sedation to a state of general anesthesia, and that it's very unpredictable, how that can happen. That is even more so an issue when you compound different agents and you use them synergistically, meaning the effect of both of them together is higher than the effect of each of them individually, and that's really synergy means. And using benzodiazepines such as Ativan and Versed or Midazolam and lorazepam in addition to propofol can often have that synergistic effect and have even a greater effect than one would have expected with either individually.
So it could result in a more pronounced decrease in blood pressure?
More pronounced decrease in blood pressure, but also a more significant depression of breathing, or a respiratory depression that can cause an absence of ventilation or apnea or cessation of breathing altogether.
And decreased cardiac output as a result, or
right? Those actually sometimes go very much hand in hand. You can have the effects that of the dilation of the blood vessels in the periphery as a result of these agents, particularly propofol, which really is known to do that, called venodilation or vasodilation. But you can also, by causing profound respiratory suppression and lowering of the oxygen levels, once there is very low oxygen perfused to the heart actually stops because of the underlying respiratory impairment or the lack of breathing. So what I'm saying is that the heart stoppage can occur, or the cardiac arrest can occur either from the medication's effects directly by causing low blood pressure, but also probably just as commonly occur because the medications together can have such a profound effect on the ability to breathe that the lack of breathing results in that lowering of the oxygen levels, and that the vital organs, particularly the heart and the brain, don't really like and result in really cardiac arrest.
And staying on this topic of the concurrent administration of both the benzodiazepines as well as the propofol, you specifically commented on the fact that Dr. Murray noted that Michael was dehydrated. What significance did dehydration play in possibly having a more profound effect on this concurrent administration?
Right. As I was earlier talking about my profession and patients we see in the intensive care unit that often have confounding issues, well, this is one of those issues. This just happened to be someone that was not in a hospital. But to be dehydrated basically means that your intravascular volume, the blood that's circulating is limited. The plasma that's circulating is limited because of losses and lack of replenishment, and that in itself can cause in some individuals a lowering of blood pressure. Now, to add to that, the additive effects of two separate sedatives, that can be another effect that kind of culminates in this perfect storm that occurred here that resulted in Mr. Jackson's death.
And you found this concurrent administration of the benzodiazepines and propofol, particularly in light of Dr. Murray's knowledge of the dehydration, to be, again, another extreme deviation or act of gross negligence?
Right. I think it's really critical to assess your patients. Every patient is different, and if you feel that a patient has risks, I mean, I gave the example of even in the intensive care unit, when we do use propofol, if I have a patient whose blood pressure is to begin with somewhat lowish, even if I do decide to use it, I have them on intravenous fluids, wide open, resuscitating them actively because I know what's going to happen next if I use propofol. In addition to that, certainly putting patients on positive pressure ventilation, which is on a ventilator, that in addition to that will have another blood pressure lowering effect. So it's very important to be aware of the patient, the underlying physiology, and do things that kind of prevent these unforeseen disastrous issues. So really these things you should always anticipate the worst, and really your patient's history, what they are like at that moment when things are still okay, really ties into that pretty greatly.
Mr. Walgren, at a convenient time, let me know for the mid-afternoon break.
Okay, just a couple more points, Your Honor. again, we're still talking, we haven't gotten into insomnia yet and the sleep medicine, but before we get there, you spoke about the failure to call 911, and you called that an extreme and unconscionable violation of the standard of care. Please explain that finding.
Right. When a patient is found out of the hospital in cardiopulmonary arrest, and one does not have the capabilities to deal with that, meaning the apparatus that we've so discussed, the first rule of thumb in basic life support is to call for help. Now, if you have someone present next to you, you tell them to call for help. But if you have nobody, the most important thing is call for help. Get the people there that have the tools and the means to really be able to help your patient. Once they've been called, obviously the efforts to perform CPR are imperative, but it's really critical to call 911 as soon as possible.
And you go on to talk about Murray's ineffective and improper CPR, and you found this to be a serious violation of standard of care. Can you describe that?
Right. What I found here were two things. First of all, when Mr. Jackson was first found, he was noted to have a very thready pulse at a beat of 122 beats a minute. And the main thing was that he was not responsive, not breathing. So the most important thing at that point, if in fact there was a pulse, was to actually deal with the breathing issue and the ventilation, the ability to move air. Certainly for a non-medical professional, if you find someone unresponsive, the most important thing is doing actually CPR, but this is slightly a different take on that just because we were dealing with a medical professional. The fact that CPR was performed on any surface other than a hard surface, meaning the floor or a backboard, is really provides for ineffective chest compression. By doing CPR, one of the most important things is to be able to compress the chest using two hands at the center of the chest. Imagine drawing a line between the nipples with two hands over the center of the chest, with standing over the patient where you actually are able to use some force and allowing the blood to circulate. Doing it on anything other than a hard surface really robs from that effectiveness of CPR and does not allow for that effective circulation. Furthermore, doing it with one hand on the front of the patient, one hand on the back, is really very difficult to imagine how you could effectively provide for that in particular on a surface other than a hard surface. The thing I would add is to even if CPR, chest compressions, are performed, even in the best of circumstances, doing everything right, you're really circulating blood at 20% or so of its normal capacity. Now, if you violate any of these rules, you know, the surface where the patient is on, the technique that's used, you're really even eliminating that number significantly. And sometimes by doing ineffective CPR, you're really actually, you know, it's really is a disservice because it's not allowing for really what you're trying to accomplish. And unfortunately, CPR technique is one that even some, many folks that even go through training are still not very comfortable with and don't always do appropriately.
I need to take the break, Mr. Lovett.
Okay.
Ladies and gentlemen, we're going to take the mid-afternoon break. As always, please remember both the